Hello and welcome to a new episode of Majlis podcast by Emirates Hospital Group. I'm Wael Berro, your host for today, and I'm a family medicine consultant at Emirates Specialty Hospital. Today we're going and dwelling into the field of gastroenterology surgery, and my guest for today is Dr. Arindam Ghosh.
Hi, hello. So it's my pleasure to be there with you.
Pleasure to have
From
you. Please tell us more about your background.
so I'm Arindam Ghosh. So I have done my super specialization in visceral surgery, as it is commonly known here.
Mm.
But basically, in India, we know it as a gastroenterology surgery or surgical gastroenterology, which basically means dealing with the diseases and the surgical perspective of those diseases, starting from the esophagus down to the rectum and anal canal, the whole of the alimentary tract, in fact. So it covers esophagus, stomach, liver, pancreas, some solid viscous, and colorectum as a luminal viscous. So we deal with specifically on alimentary surgery.
Fair enough. And we live in an area of specialization, and I think GI surgery was one of the first ones to move away from the common surgery, general surgery. So, your area of specialty is the digestive system. What are the common conditions as a patient that I would come and see you or see a GI surgeon for?
That's wonderful, actually. This GI surgery is focused and thus became an most important thing for surgery is the safety. So that has become the most important goal for a GI surgeon. And the vast area which it covers in the purview of general surgery led into specific thrusts on specific organs. And common things which are there now at present is, which I can just deal with in a handful manner. There are many. Is GI cancers,
Mm.
and that is actually just to start with the thrust of GI surgery developed. Then there are reflux diseases, common gallstone related problems, pancreas, liver ailments, coloproctology. Coloproctology, especially, are very common here, like hemorrhoids, fissure, fistula, which is not anybody's game, but it requires a special attention to have a proper and predictable care and cure. So, if I can just mention a few, there is a vast list of it, of course, but that's the thing which you can categorize to discuss with.
I mean, I've always been interested in GI surgery, so I'm going to ask you like the questions system by system or organ by organ, if that's okay.
Wonderful.
So let's start by talking about reflux.
Yeah.
Okay. Commonly, as a patient, my first instinct is to go see my doctor, my general doctor, or maybe I can see the GI doctor. Where is the GI surgeon job or role when it comes to reflux and acidity?
So the reflux and acidity has become definitely, as you said, has become a primary focus of a GI physician because of the advent of very potent medications. We call it PPI or some other acid reducing medications. So the reflux is basically the food and or the acid going up from the positive environment of the abdomen, that's the stomach, to the esophagus, the food pipe, which is in the chest, which is in the negative pressure environment. So this can happen for multiple reasons. 40% of the people in the population usually have a hiatus hernia. That means a part of the stomach which is up in the chest rather than in the stomach. So they not necessarily they all require a treatment,
Mm.
and almost 90% of our population today or tomorrow has developed once in a week at least some reflux episode of food coming up or acid coming up. That does not also require a very serious attention. But when it becomes a pathologic criteria, when it hampers life and quality of life, giving rise to different complications, then of course it mandates treatment. To start with PPI, that means acid lowering medications, that's differently available there, will be prescribed by a gastrophysician and gastrointestinal surgeon also. So most of the times these things matter along with the lifestyle modifications, especially one who is obese need to reduce weight, one who eats fast and full has to bring down the full eating habit and fast eating habit to a much slower and lesser amount of food. So these basic lifestyle changes, along with some acid reducing mechanisms, are helpful, but not necessarily always they are helpful. The gradation of reflux and its complications are unpredictable. So many a times it causes for intervention. Those interventions are minimally invasive nowadays, and that's the biggest part of it. Previously, one has to open up the abdomen to do all sorts of maneuvers to correct this abnormality, which actually has resulted from loosening of a valve from the food pipe to the stomach. Now we do all those things minimally invasive way, laparoscopically and or endoscopically. So that is a reflux cause which is very common here, and in fact, in the one of the lifestyle diseases in the whole world, we manage very predictively. So GI surgeons come there when the things are not in hand, but the results are exceedingly rewarding, almost 90% positive. So there are very few invasive, there are very few treatments which actually give rise to such effective treatment. But it requires an extreme care because that small 2.5 centimeter area of our body is so dynamic
Mm.
and it requires so much of an attention. It requires a special expertise.
Perfect, thanks. Well, two things. I'm happy that for a surgeon, you started by mentioning lifestyle modifications before, so that's always very good to hear. But at the same time, for my previous question, you mentioned safety when I asked you about common conditions.
Yeah.
And again, I'm sure that's a core thing in everything, whether a surgeon or a doctor. My next question is about the next organ you mentioned that you deal with is the gallbladder. But before I do that, related to to safety, I remember when I was medical student many years ago in Ireland, I asked my trainee surgeon, a big name, big surgeon, very famous, how long would the surgery takes? And his answer, which I still recall till today, it takes as long as it needs to, as long as it's safe. So tell me please about gallbladder
Beautiful.
surgeries and
I
cholecystectomies.
think, Dr. Weil, the thing which you have said is a very wise thing. And not only wise thing, it's a very practical thing. So gallbladder surgery is supposed to be safe. It is laparoscopically done, keyhole surgery,
Mm.
and is one of the most initial keyhole surgeries ever discovered in our arena of medical practice. It is very commonly done, and the expertise is not very difficult to attain, and the learning curve is low. Having said all these things, this has seen disasters in our practice. So we have in GI surgery, like if a GI surgeon or a me has to be asked to do a gallbladder, there are certain standardized, reproducible, definitive steps which has to be adhered to. If there is any deviation from there, it's like you are going in a lane driving in Sheikh Zayed Road. You go from here and there, you can bump and you can cause catastrophe.
Mm.
So if you have to follow those principles of surgery, which is well established in gallbladder surgery, then the results are very, very productive, reproducible. And as you said, the time doesn't matter. It can be in 10 minutes or it can take 2 hours. But those hallmarks, those milestones need to be adhered to. That is the GI surgery perspective.
Absolutely. And thank you for that. Now, and I'm sorry, I keep jumping from one topic to another because I want to ask you as many possible questions about the field or your
Yeah, GI
expertise.
surgery is interesting.
So let's move to hernias
Yeah.
because that's again another big field in your work. And more we hear of hernias repairs, and they are common. They've always been common. They used to be big surgeries many, many decades ago. I think now the recovery, the, s- the outcome of the surgery is much better. Where or tell me, please, from your expertise about hernia repairs and what's special about Emirates Group now in terms of techniques.
So, in abdominal surgery, the biggest thing which has happened over these years is a minimally invasive techniques. So, no longer we have to open up the abdomen in most of the situations. Hernia being one of the most common surgeries being performed worldwide, we do also minimally invasive manner. So, that is very crucial. Common groin hernias need to be managed by minimally invasive keyhole techniques. We have to put a foreign body that called mesh, which is very well researched, rehearsed, and tested, and time tested, and they're very safe. So meshes need to be put there. The thing which has come in the recent year of the hernia, which we provide there in Emirates Group, will be that previously hernias used to be managed by tissue repair, simple the body tissue, whatever we have, we put sutures, sew down there the defect, and that's it, or put a mesh here and there. Now, the most important thing, we have found some areas in the muscles on the abdominal wall where we can gradually sniggle in these meshes so that it is not exposed anywhere and it is not exposed to the intestine. So, the foreign body nature of that particular mesh of that disease, of that particular material, that is proline mesh or some other mesh, as we call it, synthetic mesh, are hidden between the layers of the muscles. So, this is one thing which we call a very big advancement of the hernia surgery, and we call it an abdominal wall reconstruction. So, if there is an abdominal wall hernia or a ventral hernia or an incisional hernia, the things have taken a paradigm shift, as well in the groin hernia, of course, because of a proper adherence again for with the milestones and with the things when you see in the image in a 4K vision, there are certain spots on the body and certain specific areas which can be very well identified, and this is the advancement which of hernia which has also come.
Perfect. Now, next topic, please. You mentioned the role of GI surgery in GI cancers or gastrointestinal cancers. And then you talked again and again about the role of laparoscopy because it's the biggest invention in the last few decades. How can we merge them together?
Yeah, that's actually thing. So you see, the what conventionally we know about a cancer surgery is a big incision and a mutilating operation, which is very very difficult for a patient, physically, psychologically, mentally. It really has a huge cost. So once we graduated from that to a keyhole surgery,
Mm.
we now do minimally invasive or minimally access surgery, whereby the access in the abdomen by laparoscope or by robot,
Mm.
we do with a few punctures. And but our operation inside is radical, as we used to do in open. So the access is minimal,
Mm.
but the operation is radical. So this is a beautiful combination. The marriage of these two helps us to eradicate the cancer as much as possible and without much of a mutilation, or rather no mutilation. So people, like in a pancreatic cancer, when we do a Whipple's operation with the pancreatoduodenectomy, which used to be traditionally known as Cadillac of surgery, that used to have a huge incision with all sorts of problems. Patients used to stay 14 days to 30 days in the hospital. They go home in 3 to 5 days after laparoscopic and robotic Whipples. So this sort of things I'm just telling you has fantastically revolutionized the whole GI cancer surgery. Similarly, the colorectal surgeries. There are day case surgeries which can be done in 1 or 2 days. The patient may stay with a colonic cancer, which was operated. The patient goes home. In the length of stay in the hospital, the blood loss because of a profound effect of the energy devices and the swing and sewing technologies and the camera has made it possible that the patients are much less violated, if I may say that, and the results of them have also become much better because it's become patient friendly, it's become safe because we see everything now. We don't feel only, we see, and that really gives a huge step forward for a GI cancer surgery in colon, in pancreas, in liver, in stomach, in esophagus, in all these areas. We are here to provide that. We are specially trained for that, GI cancer surgeries.
And I have no doubt with your skills, and this is nice because for people that have already dealing with the news, with the mental impact of being diagnosed of cancer, the last thing they want is that prolonged healing, complicated
Exactly.
wounds, infections, and all of kind of the morbidity associated with surgery. So I'm very happy to hear that this is kind of the trend, and I'm sure it's better for the years to come.
Tremendous. Yes, yes.
Now, my next question, and this is like going down the system and reaching the rectum and the hemorrhoids.
Yeah.
Hemorrhoids are very common problems, and a lot of it again is managed at primary care level, some of it a bit more invasive, but there's always a fear about surgery. What's the role of, or well, actually, what's your role in managing hemorrhoids, please?
So there is a this is such a common disease,
Hmm,
and this has happened because we have stood erect, evolutionary. Nobody gets hemorrhoids except we and the gorilla.
hmm,
There are three diseases which we got because we stand erect as man. That is hernia, that's hemorrhoid, and that's the varicose veins. Now the hemorrhoids, our daily practice, our daily diets are constipating diets, high calorie, low fiber diets, which barely reaches the colon. And so the volume of the stool and other things and the water it brings down in the colon, in the intestine, are low. So the patients develop constipations. Plus, there are bad defecatory habits, which lead to hemorrhoid very commonly. The problem is that people think that, and it is true that it's a hemorrhoidal treatment is painful. So there are so many jellies and oils and other things which do not work. Period.
hmm,
Things which work are cutting and sewing, but they are painful.
hmm.
So that area is more sensitive than the skin of our face. People don't understand that. But this is so important. And because of the privacy issues and other things, they come late. And in situations like this cutting and sewing causes a lot of discomfort to the patient in terms of length of stay, in terms of work problems, going back to the work and normal activities, etc. If you can marry this eradication procedure with minimally invasive techniques, then that's the best thing. So you have to you have to judge very carefully and wisely how can you marry a laser or a microwave techniques along with the open techniques.
Hmm.
So if you do more lasers, there will be if you do more lasers, there will be less healing all the time. So there will be recurrence. If you do more operations, there will be more pain. So you have to marry it together, and that's the beauty of the present day hemorrhoid treatment: laser and the open surgery, the perfect marriage. If it happens, it really helps a lot of people. They go back work in a couple of days, and the normal thing continues.
And I'm sure your approach is individualized because every patient is
Individualized.
different. Absolutely.
Absolutely.
Now, I'm going to move to a topic that I'm personally very interested in, and I'm sure most of our audience is interested in, is weight loss. Weight loss, many years ago, it was mostly your field. Like you go to the surgeon, you do bypass surgery, and then you lose weight. Of course, with lifestyle change. Now we have medications that help weight loss, and the evidence is quite there. And I think finally, as a primary care doctor, I have a tool to offer my patients. But that doesn't mean surgery is gone. I'm a strong believer of what we call MDT, the multidisciplinary approach. You and I working together for the best interest of the patient, irrespective of the condition. So tell me, please, about surgery, weight loss, and your role as a doctor, please.
Wonderful. So, yes, I'll just tell in one or two sentences because it's a huge topic.
Of course.
So, what is the position statement of if so now it is internationally? they're coming up with this, that the obesity managing medications, OMM, or all these medications like Mounjaro or
Wegovy. Yeah.
semaglutide and all those things, which they are very, very good, very, very, very effective. So they have to be carefully prescribed. I will not ask for that. You just get an OTC for a Mounjaro or things like that. There are harms
Mm.
and things to be looked into, the details of it. As far as the bariatric surgery is concerned, you cannot reduce predictably with lowering of the morbidity on a patient who has got a 40 or 45 BMI. That patient is going to require bariatric surgery for sure. What we can do is that in bariatric surgery, there are patients who come with with such an increased amount of weight with a lot of comorbidities, like heart diseases, like liver problems and things like that, and uncontrolled diabetes, etc., etc. So in those situations, if you can reduce at least 14%, 10%, or 15% of the weight, that gives a tremendous lowering of the risk of a bariatric surgery per se. Because so the OAM at that particular point, that medications help you to optimize the patient to go for a bariatric surgery, which is going to be ultimately the most important treatment modality, as you said, in a patient who is morbidly obese. Remember, the bariatric surgery is for morbidly obese.
Mm.
It is not for a 30 BMI patients. It is not for 32 BMI patients. It is for BMI patients of more than 35
Mm.
with comorbidity, 37 or 40 without any comorbidity. We have to adhere to these few rules. They are changing gradually, but these are very important things which one must understand. So you can treat a plump patient with Mounjaro or other things, so overweight, obese, and severely obese, but not morbidly obese. If you are the patients are morbidly obese, you have to make sure that this patient will probably require bariatric surgery. Time will tell whether the bariatric surgery will not be required at all because of the potency of these medications, which are being coming one after another in the pipeline. And I hope so, if it comes. But ultimately, it's the lifestyle modification and the food modification, dietary challenges, which need to be addressed for all weight loss medication or weight loss management programs.
Uh, and again, like you said, it's a very complex topic,
Very
as
complex
is
topic,
obesity,
yeah.
complex, morbid, complex condition, but it's best addressed with your expertise, the primary care, lifestyle,
Yeah.
and the medications definitely have a role, but surgery is still there as a modality
Yeah,
for the right
yeah,
person.
correct.
Dr. Ghosh, it's a pleasure having you over. Like, I'm sorry, we talked about so many topics and we jumped right and left,
Yeah.
but thank you for entertaining all our questions. Any last minute or any kind of take home message you want to tell our audience today?
For a GI surgery, yes, of course, I would be saying that this is a new specialty, not very commonly acknowledged, though. But GI surgery focuses, and because of that focus, causes a lot of safety and can help people with challenging disorders, not very easily manageable by common general surgery practice.
Thank you very much. And this brings an end to today's episode of Al Majlis podcast by Emirates Hospital Group. Please stay tuned for another episode coming soon. Thank you. And thank you, Dr. Ghosh.
Thank you, Dr. Wael.